All right, thank you, Robin, for inviting me to come speak here tonight. As Robin mentioned, my name is Dr. Stephanie Fall, and I am a psychiatrist at Vanderbilt. Just to give you a little bit of background and what it means to become a psychiatrist, that means that I completed my undergraduate degree and then went into medical school, where I completed 4 years of medical training before going into psychiatry as my specialty. And psychiatry requires a 4-year residency training program. So I started at Vanderbilt in 2017 with the residency training program and completed up my 4-year program at Vanderbilt in June of this year. So then I started on as faculty shortly after finishing my residency training. So been here in Nashville for just over 4 years now. I've really enjoyed my time here and obviously have really liked working for Vanderbilt, so that's why I've stayed. In particular, one of the reasons why I decided to stay at Vanderbilt is because of our focus on caring for patients with disorders that we'll talk about today. So I am part of the early psychosis program here at Vanderbilt, in particular on patients with new onset or early onset psychosis. And so we have a coordinated specialty care program here that allows me to take care of patients both in the hospital setting as well as in the outpatient clinic setting, working with patients mostly on medication management. So I was asked to come talk today, and typically Dr. Stovall does this, but he wasn't able to make it and had asked that I step in, which I was very excited to do. So I was asked to talk mostly about the different diagnoses and maybe a little bit about what really are the main characteristics of these diagnoses, how we diagnose a patient with one diagnosis versus another one, maybe how diagnoses seem to change or evolve over time. And I hope to clarify some questions you guys might have, because a lot of this can be fairly confusing and convoluted and murky. And if you are feeling that way right now or during this talk, that's okay, because I'll be frank with you that in the field of mental health, things are not always very black and white. And so we often kind of work in that gray zone. So we'll talk a little bit about diagnoses, what are the main characteristics of these diagnoses, how they might change or evolve over time, some of the main questions I get a lot about diagnoses, and then also just the importance of recovery and talking about how to best support a loved one who might have a new diagnosis of bipolar disorder, schizoaffective disorder, schizophrenia, something of that sort. Okay, I want this to be conversational, so as I'm going along, please do not hesitate to unmute yourself, interrupt me, ask questions, and that way, hopefully all of your questions will be answered kind of along the way. Okay, so to start off with, I have some notes off to the side, so I'll just be kind of glancing over to make sure I don't miss anything. So to start off with, let's just go through some of these different diagnoses. So I want us to think about diagnoses kind of on a spectrum, because there's a lot of similar characteristics between these different diagnoses. And so you might hear me mentioning pretty similar symptoms that will fall into like all of these different categories, but there's some more discrete characteristics that I'll point out about each of them. So to start off with the bipolar spectrum diagnoses, you really will mostly hear about the diagnoses of bipolar 1 or bipolar 2. People might also refer to it as like bipolar type 1, bipolar type 2. And the main characteristic feature of bipolar 1 disorder is mania, or a manic episode. To be diagnosed with bipolar 1, you have to meet criteria for at least one manic episode in your lifetime. And what is a manic episode? It's probably similar to kind of what you picture, where somebody is a bit more elevated or agitated. It can come with distractibility. They might be more irritable or impulsive or reckless. They typically have a decreased need for sleep, meaning they can go several days with very little to no sleep. And it's not that they can't sleep, like insomnia, it's that their body and their mind just really doesn't require sleep at that time. They also might be talking faster than is normal for them, or with kind of more of what we refer to as the pressured speech. So talking very fast and like they have to get it out and they have to go, go, go. That also can happen with their movements too. Like you might notice that they're actually moving quicker than is typical for them. And again, they can sometimes be more impulsive or reckless, and that can be dangerous if somebody is engaging in behaviors that could potentially put their life or someone else's life at risk. Mania, those symptoms that I mentioned have to be present for at least 1 week for it to meet a full criteria for a manic episode. And one other side note I want to make here is that as I'm going through these diagnoses, you might notice that there's a lot of like little caveats of time criteria that has to be met and all of that. And I'm happy to answer all those questions you guys have about that, but I don't want us to get caught in all the details. I don't want you all to worry too much about all these tiny, minute details, because that's what our job is, to kind of differentiate between all these things. So, but the main feature to look out for with a bipolar type 1 diagnosis is a manic episode. Typically, people with bipolar 1 will not only have manic episodes, but they'll also have major depressive episodes. And they can actually have like the lesser severe manic episodes, which include hypomania. Bipolar 2 is characterized by hypomania. If you have mania, you can't have bipolar 2, you have bipolar 1. Hypomania is an episode of the same type of symptoms as the mania has, with the impulsivity, distractibility, decreased need for sleep, talking more, moving quicker. However, the symptoms tend to be less severe, so they're not to the level of severity as mania, and they also don't last as long. So the symptoms will last at least 4 days, but it doesn't need to last quite as long as to meet criteria for a manic episode. Bipolar type 2 not only has the hypomanic episodes, but they will also have a major depressive episode. It's very common in bipolar 1 and 2 for, if a person goes into a manic or hypomanic episode, for them to then, after completion of that episode, to then go into a depressive episode. So we kind of think of it as the person is kind of leveling out in that way. Like they go up into mania or hypomania and then down into like more of a depressed state before they hopefully then will level out from a mood standpoint. So those are the bipolar spectrum diagnoses. And you might have noticed I didn't mention anything yet about psychosis or psychotic symptoms. And that's because I'm going to go through a lot of specific disorders related to psychosis in particular. However, you can have psychosis with bipolar disorder, but it's only with bipolar 1. So bipolar 2 will not come with any psychotic symptoms, but bipolar 1 can. And typically it's going to be with that manic episode.
Right. Symptoms like what?
Jill, I heard you asked a question, but I couldn't understand it. Can you say it again?
Kind of psychotic symptoms can come with bipolar 1.
Right. What type of symptoms?
What kind of things happen that are psychotic with bipolar 1?
Yeah, okay, so that's a really good question. Really, so there's no specific criteria that would be required for you to be diagnosed with bipolar 1 manic with psychotic features, other than just saying some sort of psychotic feature. So I can tell you that what we typically see in terms of the psychosis that would accompany a manic episode tends to go along with the more manic presentation. So that tends to have the delusional thoughts that are more grandiose in nature. So kind of having beliefs that you are important or carry some sort of a special purpose or mission. So the grandiosity of the grandiose delusion can kind of go along with the grandiose nature that comes in and of itself with a manic episode. They also, I would say that we can classify when somebody becomes more disorganized or scattered in their thoughts, or become more disorganized with their behaviors, maybe acting or doing things that are really out of character for them. We can classify those symptoms as bipolar symptoms. And in that way, we would then classify that person as having mania with psychotic features.
I ask you one quick question. This will be
Yeah.
that. My adult daughter has diagnosed bipolar 1, and I met with her one time at a restaurant to pass off papers from like my living will and things like that. I was having surgery, and she showed up agitated, really, and by that she thought my lawyer was stupid and I think. But by the end of the meeting, she thought that everybody was staring at us, that a lady, the server, had come back over after because I told her, I said, I think it's best if I just leave. Here's some money, because she was escalating. And she thought the waitress came over and said, phew, I'm glad she's gone. All that. And none of that happened.
Yeah.
Because to get a reality check, I went back the next day and talked to the waitress after she was off. And none of it happened. And it scared me to death because I'd never seen that happen before. Now, I was going in for a major surgery that her dad had died from 3 years earlier. I don't know if that created stress or what, but what is that? I've wondered for a year and a half now, what happened?
Yeah, so I appreciate you bringing that up. That's a really good question. So mania in and of itself can come on fast. And so really a manic episode based off the criteria means that the symptoms last at least a week, but a week is really no time at all, and the symptoms can come on pretty abruptly. And so I don't know exactly what was happening in the case with your daughter, though it sounds like she was acting very different from what is her typical self. And maybe she was experiencing some of the symptoms of mania that could include like the irritability, the impulsivity, and maybe not perceiving reality quite like how you perceived it. And that's really kind of at its most basic level, thinking about psychosis is to identify it as the person experiencing psychosis is experiencing a different reality than what we are experiencing, however you want to define reality. So they might have thoughts or beliefs that don't match what we are experiencing, and they might have different perceptual experiences, like hearing things or seeing things or feeling things that we can't experience. And so again, with bipolar type 1 disorder, they can have those sorts of symptoms of psychosis, but it would only come about during an active manic episode. It would not come about when they are not in a manic episode.
Well, she came over to my place the next day, still yelling and carrying on and saying I was trying to make her look crazy. But here's the thing. She used to work at Genrose she's brilliant.
Yeah.
Up at Rochester, for Mayo. And it's all very confusing for me, but I'm trying to learn.
Yeah, so I appreciate you being here just for that reason in particular, that all of this is very confusing and convoluted at times, and especially if a loved one develops these symptoms pretty abruptly, it can seem like it's pretty abrupt, and it's such a different change from how they normally are, and it can be very confusing and very scary for those who care for them. So just to make sure we're moving more towards the realm of all these other disorders, the psychotic disorders, I want to touch on kind of a few major definitions for us to think about before I go into the specifics of these different diagnoses. So first of all, we've mentioned that maybe a person with psychosis has different beliefs or thinks differently than you or I might think or believe. And really we can classify false beliefs or thoughts that again don't necessarily align with what we see as reality to be delusional thoughts. And so really delusions we define as fixed false beliefs. And an example could be that someone is out to get me or out to harm me in some way. I'm being targeted by a person, and I'm fearful because this person or this entity is coming to get me. So there's different types of delusions. The one example I just gave would classify more as a persecutory delusion. So someone is trying to persecute me, essentially. There's lots of different types of delusions. I already mentioned grandiose delusions too, and that comes with that grandiosity of a feeling of I am special and important, and I've been given a special mission or something like that. There's lots of different types of delusions, but think about delusions as these fixed false beliefs, whereas hallucinations are false sensory perceptions. So lots of different types of hallucinations, but most commonly what we see are the auditory hallucinations, which essentially means that a person hears voices that others are not able to hear. There can also be visual hallucinations, so seeing things that other people cannot see. There can also be tactile hallucinations, feeling things like on your skin that other people cannot feel, or even olfactory hallucinations, smelling things that people can't smell. There's a lot of different types of hallucinations. The most important thing to understand is the auditory hallucinations, so voices. So what I'm going to do now is, now that we have those definitions under our belts, I want to talk through some different diagnoses within the realm of psychosis that you may have heard of before. And so with these, what's important to think about is the time course. So I'm going to talk about brief psychotic disorder, schizophreniform disorder, and then schizophrenia. And really, these diagnoses are all very similar. The main difference that we're needing to use to differentiate between them is the time course. So basically, if a person comes to see us who is having symptoms of psychosis for only a short period of time, let's say a week, it's not, their symptoms haven't lasted long enough for me to say you have schizophrenia. Though I might be concerned that they may develop schizophrenia down the road, the more correct diagnosis at that point would be brief psychotic disorder. Okay, so if they have symptoms of psychosis, and I'll go through more specifically what those symptoms are, but if they have symptoms of psychosis that have lasted at least one day, but less than 1 month, at least one day, but less than 1 month, it's brief psychotic disorder. If they have symptoms that have lasted at least 1 month, but less than 6 months, it's schizophreniform disorder. And then if they have symptoms that have lasted at least 6 months, it's schizophrenia. So those are like the three main, what we refer to as the primary psychotic disorders, meaning it's psychosis due to a psychiatric condition. It's not psychosis due to a drug or a substance. It's not psychosis due to some medical or neurologic condition. And it's not psychosis that's associated with bipolar disorder or associated with a depressive disorder. It's just pure psychosis in and of itself. Those are like the three main ones you can think of, and just look at it based off the time course. And there's a question in the chat about the second one. It's schizophreniform. And so that one lasts at least 1 month, but less than 6 months. So a lot of people are not diagnosed with brief psychotic disorder or schizophreniform disorder, however, because unfortunately, a lot of people who experience psychosis don't receive care right away for a variety of reasons. And when they do eventually make it in to see providers like myself, when we gather the history from both the patient and their family, it really will turn out, based off history, that they've had these symptoms for longer than 6 months. And so they might, from the get-go, receive a diagnosis of schizophrenia and really never have received those other 2 diagnoses. So it's not a requirement that someone has those other 2 diagnoses before they receive schizophrenia. There's another question in the chat. Can you explain where schizotypal personality disorder fits into that spectrum? Okay, so schizotypal personality disorder is a personality disorder. So it is not what we refer to as a primary psychotic disorder. I can do a whole nother talk on schizotypal personality disorder, but what's important to think about with that is personality disorders, and that one in particular is diagnosed when someone is an adult. So it does have a time criteria of them being 18 or older. And it really has to involve a variety of symptoms that typically include magical thinking, an eccentric way of viewing themselves and the world around them. Oftentimes they have odd beliefs and they might dress kind of unusually. They typically like to keep to themselves, but they don't cross into the realm of active psychosis. So even though they have these more magical beliefs or a more magical way of thinking, they don't have delusions. They don't have hallucinations. So again, it's kind of this like fuzzy gray line, difficult to clearly differentiate sometimes. But a true schizotypal personality disorder comes with just the personality traits that I had mentioned. And for it to be diagnosed as a personality disorder, it has to impact their functioning in some way. But it's pervasive across time. So it's like always present. When you look back in time, it was present years ago in early adulthood. It is more than likely going to be present throughout their life unless they receive treatment. But personality disorders are treated very differently than other types of psychiatric disorders. So we wouldn't necessarily, for instance, we wouldn't necessarily use medications in someone with schizotypal personality disorder. It would be more therapy, like talk therapy, that could be helpful. So I hope that helps to answer that question. So now we've gone through those like the three primary psychotic disorders, the brief psychotic disorder, schizophreniform, and schizophrenia. And I've talked about the time course that is needed for each of those. But what are the symptoms that are needed for each of those? The symptoms include some that we've already mentioned: the hallucinations, which are the false sensory perceptions, which most commonly for a primary psychotic disorder, that's going to be hearing voices. So it's not as common to see things, to feel things, to smell things. The auditory hallucinations or the voices, far and beyond, is what is most common when within the hallucination realm. The other symptom that we've already talked a little bit about is delusions, which are those fixed false beliefs. I would say that the most common delusions that I see in folks are the persecutory delusions, which again is that feeling that they are being persecuted against, or someone is out to get them, someone is targeting them. They are typically then presenting as quite fearful and anxious, because if you can imagine, if you truly felt that someone was out to get you, out to harm you, stalking you, following you, trying to harm you in some way, that would be terrifying. And so that's typically how those folks will present. The other main kind of symptoms of psychosis that we will see are disorganized speech, which I also had mentioned before. It kind of can be more scattered, like someone is talking to you and maybe they're using words like English words, but they're not put together in the right way. And it can be minor to where you're following them, but then you're not following them. Or it could be that they're kind of talking in circles, or it could be so severe that it's just words, but they have no connections to each other, which we refer to as word salad, like just individual words kind of thrown together, but it's not actually forming sentences. There's no real way that they're actually communicating their information. It's just kind of words, but it doesn't make sense. So for us, it can be difficult when we're talking to someone like that, because we can't really get, it's obvious that the person is trying to communicate with us and give information, but it doesn't really make sense to us. And it can be very frustrating for families to be talking to a loved one who's not making any sense. And it can, I would imagine, be very infuriating. But we see that as one of the main symptoms that we can see in patients with psychotic disorders. Typically, in my experience, what we've seen with people who have that disorganized speech, their thoughts are disorganized and scattered. And so it's not that their thoughts are linear and organized, but their speech is scattered. It's both. Their thoughts are kind of scattered and all over the place, and it's coming out in their speech as scattered and all over the place. You'll often hear us in psychiatry use that term disorganized a lot, basically meaning not organized or not linear. And so that term disorganized can also be applied to disorganized behavior, which that basically just means that there's a lot of different ways that you can define it, but basically it just means that someone's behavior, meaning their like actions, it's not within a realm of what would be considered normal for them. So it could mean doing things that are erratic, doing things that don't make sense, leaving the home in the middle of the night without any clothes on and going across the street to the neighbor's yard, for instance. Like they're engaging in a behavior that doesn't make sense, but to them in the moment, it probably had some sort of a purpose, or they had some sort of a goal with it. But to us, we're not able to see that, and we don't understand why they're behaving that way. The other type of disorganized behavior that you could think of is catatonia. Catatonia is another topic that could have its own hour-long discussion, but just think about catatonia as an alteration in someone's movements. Is kind of the best way to think of it. So there's some sort of abnormality with their movements. Catatonia can be seen with a lot of different psychiatric disorders. It can also come with different medical and neurologic disorders, but it can be one of the symptoms seen with psychosis, seen in like schizophrenia, for instance.
Paul, would you, with catatonia, I've always heard that can also be kind of dangerous as far as making sure that when you see that, you get someone in right away.
Yeah, that's a really good point. So catatonia can present in a variety of different ways. Oftentimes, what we see is either the stuporous catatonia or the excited or agitated catatonia. So the stuporous catatonia is when someone really withdraws within themselves. They're not interacting as much. They're not talking as much. They're not moving very much. They really might become so still and stuck almost, like that they kind of lay in bed and don't move. They will oftentimes stop eating and drinking. And so in those situations, it can, if they don't receive the appropriate care, it can worsen to the point where they're not eating or drinking for days on end, which obviously can become life-threatening. Catatonia can also, if it's not treated appropriately, can worsen in some situations to a more severe form of catatonia, which we refer to as malignant catatonia. Malignant doesn't involve anything with cancer in this case, But basically it just means that it's a really severe form of catatonia, and it comes with vital sign changes. So like heart rate or blood pressure can get really out of whack to the point where it can be life-threatening for that individual. That other form of catatonia that I mentioned, the excited or the agitated catatonia, presents very differently from the stuporous catatonia, and it can be very difficult to identify because the person might just seem like they're, for example, in a manic episode, because they might be more agitated or excitable or moving about a lot. Because catatonia is kind of this enigma, it's very difficult to diagnose at times. We have a specific criteria that we follow, where it's this scale with these symptoms, and it's this exam that we do with patients so that we can very clearly go through the different signs and symptoms that can come along with that diagnosis. And we use that scale to then follow them over time in treatment to make sure that they are improving and responding to the appropriate treatment. There was another question in the chat about would that present in people with Parkinson's? So Margaret is asking about if catatonia can present in people with Parkinson's, and catatonia can present with different neurologic disorders as well as psychiatric, but it's difficult here in that Parkinson's is a movement disorder, and so there are some similar features that you could see that can overlap between catatonia and Parkinson's. And there's another question about, can catatonia manifest with the person stating that they are tired and just stop working or doing anything, but continue saying they need to rest? This is the situation my child is in now. So again, this is why it's just not very black and white. I'm not able to tell exactly just in your sentence you just put in the chat there exactly what is happening with your child. But what I can say is that what's tricky about that stuporous form of catatonia, especially when the symptoms are mild or not that severe yet, is that it can kind of present similar to a lot of other things, like even depression. In depression, people will kind of withdraw into themselves, isolate, maybe not be as engaged, maybe not eat as much, their appetite might be down, they might not talk as much, and so there can be some overlap there. But again, catatonia comes with some pretty specific movement changes, or what we refer to as psychomotor abnormalities. So there's an exam that we do on patients to really clearly differentiate between, is it catatonia or is it something else, whatever that something else might be.
Dr. Fall, we have a hand up with Lynn Hayes. I think
Yeah.
Lynn had a question. You want to unmute there, Lynn? Okay, there you go. There you go.
So what I'm trying to determine is my adult son he had a medicine change. Before the medicine change, he was fine. He was going to work. He was doing everything that he needed to do. He was sort of happy. And then the medicine change came, and then suddenly he decided he didn't need to go to work. I'm just tired. I just need to rest. I need to eat celery. So I'm just, the last time this happened, he became it was not good. Yeah. So I'm sitting here scared to death. I don't know what to do or where to take him.
Yeah.
To even ask the questions to find out if we're going to a problem. It looks to me like we're going to a problem.
Yeah.
Because he's very like a robot, he's suddenly not talking to anyone. He's just withdrawing, staying in his room, not making a lot of conversation. And he's normally, talkative and happy, but now he's not, and it's scaring me.
Yeah. So just in hearing what you've said, it does sound like your son is needing to be evaluated by a mental health professional to be able to differentiate between, you know, what we've been talking about with, is it potentially those symptoms of catatonia we've discussed? Is it related to mood changes, or is it more in the other with the other symptoms of psychosis that we've talked about? So it's really hard to tell. I can say though that I would recommend that he get evaluated soon, and that recent medication change is kind of drawing my attention a little bit. That maybe there's something up with that medication change. Maybe he's not tolerating it as well, or maybe it's not as effective for him. And so I would definitely reach out to whoever the most recent provider was, would probably be the best next step.
Well, the real problem is he doesn't have any insurance. So what do you think? I should just take him to the emergency room, or?
Lynn, I'll jump in on that, Dr. Falls. So don't worry about that. There are things like the behavioral health safety net. There is the crisis stabilization unit that is a 24-hour walk-in over there at the mental health cooperative. You've got over at Vanderbilt, there's an ER. So the main thing is you actually have a condition here that does need to be seen. And if he's willing to go, and some of you know how hard it is once you've got somebody, if they're not willing to go, but if he's willing to go, you scoop him up, get him in the car, and you go.
Okay, well, at this stage, he's very willing to go.
Oh, that's great.
Very willing to go. But we've been further where, you know, it gets combative and it just gets further. I don't want it to go further.
Yeah.
Okay. Thank you.
Yeah, of course.
Can I, and let me give out a number, please, too. If you are in Davidson County, there's a 24-hour number I want you all to have, and that is the Tennessee Mental Health Crisis Line number, and that is 855-274-7471. That's 855-274-7471. If you call it while you're in Davidson County, it will answer at the crisis stabilization unit over there at the mental health co-op. If you call it outside of Davidson County, it will answer at whatever crisis stabilization unit is closest. They will help you as a family member. They will give you guidance.
Okay. Great questions. We can get back into the conversation with the main symptoms that we see with psychosis. Before I move on, though, were there any other questions about catatonia?
I just want to make sure we have time for schizoaffective disorder, because that's one we always hear about.
For sure. So before we get there, I just wanted to very quickly mention one of the other main symptoms of psychosis that we can see with all of these psychotic disorders. And one is its negative symptoms. So I'll just briefly mention what I mean by negative symptoms and kind of what symptoms can come along with that. So we refer to some of the symptoms of psychosis as either being positive or negative. Positive means that you're adding something in, and negative means you're taking it away. So the positive symptoms can include the hallucinations or the delusions. So it's like the hallucinations are kind of added in to their experience, and the delusions are kind of added in on top of their typical thoughts. So again, the paranoia, thoughts of persecution, or hearing voices are positive symptoms that are added on to a person's experiences. The negative symptoms are symptoms that are like taken away from the person or reduced. So that can include like a reduced motivation. They're just not as motivated to do things. That can include a reduced intensity of emotions. They might not express emotions quite as much as would be typical for them. They also just might not be as interested in a lot of things. They might not share as many thoughts as they typically would. So there's a lot of things that can come along with that negative symptoms or a negative syndrome. But basically, you can think about it as things are being taken away or reduced. Okay, so then to move on from the schizophrenia diagnosis, the next one then to talk about is schizoaffective disorder. And this one can be kind of confusing. And it can be confusing not only for patients and their family, but also for providers. Because as you'll see in what I talk about, there's a lot of overlap between schizoaffective disorder, schizophrenia, and bipolar disorder. And so it really requires an experienced clinician to sit down and spend a lot of time with the patient and a lot of time with their family who know them well to go through the time course, to go through what their symptoms have looked like over time. A lot of these diagnoses and schizoaffective in particular can just be quite tricky and differentiating between symptoms and differentiating between when this symptom was present and this symptom was not present and when did they overlap and that sort of thing. So schizoaffective disorder, the schizo part is related to the schizophrenia portion, and then the affective part is related to an affective illness, and affective relates to a mood disorder. So an affective illness is like depression or bipolar disorder with mania. So basically, schizoaffective disorder is a psychotic illness that comes with a major mood component. So they essentially meet criteria for schizophrenia. They meet the main criteria for schizophrenia, meaning that they have like the delusions, the hallucinations, the disorganized speech, the disorganized behavior, plus minus catatonia, and they may also have negative symptoms. In addition, they have a major mood disorder, and it's either depression or mania. And so schizoaffective disorder is classified then as a person having schizoaffective disorder depressed type or schizoaffective disorder bipolar type. If they have the bipolar type, it means that they have had a manic episode before in their life. If they're just the depressed type, that means that they've experienced depression, but no mania in their life. What can be difficult to differentiate between schizoaffective disorder and schizophrenia is that the symptoms of psychosis can be the same, can be identical, but it's looking at the mood symptoms and seeing when they occur and how often they're occurring. So it's not unheard of for a person with schizophrenia to also have depression. And we can diagnose someone with schizophrenia as having schizophrenia and also a separate major depressive disorder diagnosis. When we're diagnosing someone with schizoaffective disorder, though, we're saying that they have the psychotic symptoms while they're having prominent mood symptoms that are present for the majority of the illness. Okay, so think about it like this. In schizophrenia, the mood symptoms are not expected to occur without psychotic symptoms. And the psychotic symptoms are almost always present, but the mood symptoms will come and go. Whereas in schizoaffective disorder, the psychotic symptoms may or may not be present during the times when the person is having their mood episode. And also, they are likely to experience severe mood symptoms that accounts for more than half of the total duration of their illness. Whereas in schizophrenia, you can experience these mood episodes, but the total duration of the mood symptoms is more brief compared to the duration of the mood symptoms in schizoaffective disorder, and it's certainly brief compared to the duration of their psychotic symptoms. So again, it can get very convoluted and tricky. And if you're feeling confused, don't worry, because we also can find it difficult to tease these apart, and it takes time. When we meet an individual for the first time, we're not able to give a clear-cut, confident diagnosis between these. We can pretty easily tell that there are psychotic symptoms, and we can pretty easily tell that there are depressive symptoms, but it might take us some time and some time getting to know the individual to really be able to tease this apart. But the main thing to know is that with schizoaffective disorder, it's either depressed type or bipolar type. The mood symptoms are predominant, and they're present for the majority of the illness, and their psychosis may come and go. Whereas in schizophrenia, the mood symptoms are not as predominant, the psychosis is more there than not. A lot of the treatment can be the same between the two of them, but there can be some differences there. The other thing that I wanted to note and kind of differentiating those is that when you're looking at schizoaffective disorder, bipolar type, you're having to also then differentiate that from bipolar type 1 with psychotic features. So as you can see, there's a lot of overlap with all of this, but we work hard to differentiate these diagnoses by getting a good history and working with the patient over time. One thing that can be helpful in differentiating between a bipolar disorder diagnosis and a primary psychotic disorder diagnosis is that in schizophrenia, and often in schizoaffective disorder as well, there's typically a prodrome period where a person has a change in thought, a change in the way they interact with others, and subtle like personality type changes or mood changes that can happen even years before they have their quote unquote first break. And what I mean by the first break is kind of the first time that their symptoms of psychosis are outwardly showing themselves. So there can be this year-long prodrome phase leading up to what we refer to as like an acute phase of psychosis. So that sort of prodrome, acute phase, and then recovery is pretty typical for a primary psychotic disorder, whereas you don't see that those three phases as often with a bipolar disorder, if that makes sense.
Yeah.
I wanted to now move on to the idea of diagnoses changing over time. And again, just stop me if there's any questions about what I've talked about or anything, any other questions that come up as we go. So I've already mentioned that if we meet someone who is early on in experiencing psychosis, and maybe they're even just a week into experiencing psychosis, then we would give them that diagnosis of brief psychotic disorder. And then if we were able to follow them over time, they could transition into the schizophreniform diagnosis or schizophrenia if their symptoms remain present long enough to meet the time criteria. And so you can see that there is, in that case, kind of a natural progression between those diagnoses. And so it would be understandable how a person's diagnosis would change over time. Ideally, we get them into treatment, we're working with them, and they're responding well to treatment, and maybe we can improve their symptoms to the point where they don't transition, but in some cases they transition, and it's understandable that they would, just based off as more time goes on, they're more likely then to transition into that schizophrenia diagnosis. However, sometimes it happens that a person is diagnosed with schizophrenia, and then the next provider that they see says that they actually have schizoaffective disorder. And so why would that be the case, and that is confusing and frustrating for the patient and the family. And what I want to emphasize here is that diagnoses can change, not necessarily only because of change in symptoms in the patient, but maybe even just change in providers. Providers can see things differently. And providers maybe will have a different approach in working with a patient. Or maybe a provider will have spent more time getting to know a patient, like in the outpatient setting versus just in the hospital and the acute setting for a few days. And so it all depends on following a patient over time, getting to know them as best as we can, getting to know their history as best as we can, to give our best estimate as to which diagnosis seems to fit them the best. And so it's possible that somebody could be diagnosed, let's just say, with schizophrenia when they're in the hospital. They discharge back out to their community provider, and their community provider gets to know them over 3 years and says, actually, it's schizoaffective disorder. I would say that that doesn't mean that the inpatient provider was wrong or incorrect. It's that they chose that diagnosis based off the information they had at the time. And maybe the end of the patient actually hadn't had a mood episode yet. And maybe their mood episode that would really then meet the criteria for it being schizoaffective disorder came later. And so then the diagnosis just changed. So that's another thing why I mean by in mental health, we kind of work in this gray zone. It's not as easy as let's take a blood sample and you have diagnosis X. We really need to work with you over time, get to know you well, and our diagnoses can fluctuate. It also is
Dr. Fall?
Yeah.
We're at the 5-minute mark. I just want to let you know.
Okay, thank you so much.
Mhm.
I also just wanted to mention too that co-occurring illnesses are very common. So it's very common, just for example, for someone with schizophrenia to have an anxiety disorder, such as social anxiety disorder or panic disorder. And so it's very common for there to be other illnesses that are present that the provider may diagnose from the get-go, or it may take some time before the other disorder is diagnosed. Given that we only have a few minutes here, I'll pause and see what questions have come up. If there are no specific questions, I'll just make another point here. This is what I get from families a lot of the patients I see are questions about how do I deal with this? Like, how do I respond to my loved one when they are quote unquote talking crazy, or when they're saying things that don't make sense, or when they're telling me that this thing is happening that I know is not actually happening. And I would want to encourage you to first check in with yourself and see how you're feeling, because you're likely in that situation feeling some combination of annoyance, feeling irritated, frustrated, or scared, sad. And what I would encourage you when you're in this fear, what I would encourage you when you're in that situation is to first take a deep breath and check within yourself to see how you're feeling, because we want to try to avoid putting our distress onto our loved one. So we don't want our first response to be, oh no, this is bad, you're getting worse. Because that, as you can imagine, might heighten the situation, and make everyone involved feel maybe more stressed or panicked. Really, what I encourage people to do is to be as neutral, supportive, and loving as possible. So if you are their mother, if you are their grandmother, if you are their father, their cousin, whatever, that is your role in that person's life. And so you are there to love and support them unconditionally. And you can say remarks to them of, it sounds like you're really stressed right now. Tell me more. So you can kind of put it back on them in a way that's very neutral, just that you're showing interest, that you care about them, that you see that they're upset, that you see that they're scared or stressed or fearful, and you want to learn more, but you're coming at it from a more open, non-judgmental way rather than immediately throwing your worries onto them. Also, distraction is very helpful. So even saying something like, wow, it sounds like there's a lot on your mind right now. Do you think it would be helpful if we take a walk? Or maybe we should listen to some music to help distract our thoughts. Things like that can help in the moment to just kind of shift gears with their mind. But trying to just be as calm within yourself, even though that's so hard, trying to first check in with yourself before you respond to the loved one is important.
All right, do we have any final question, or because I think this was, Dr. Fall, this was excellent. And I really, I think all of us appreciate what you've shared, and you've taken some topics that can be, like you said, very gray at times. And I think you've really helped to define some of those. So we truly appreciate the time that you took. So we want to thank you very, very much. And if you guys know how to do, those of you that I know might be a little, there are reactions that you can use, and you can clap hands or just say thank you. So thank you very much for the time that you took in preparing this for us and in sharing it with us. Thank you so much.
You're welcome. Thank you all for having me.
All right, thanks a lot. So, folks, we are going to be moving on to Dr. Joseph Pandit. Dr. Pandit is a friend to this organization. We've had him, gosh, it's been several years, and we are so grateful when he presents with us. Now, for some of you, you may have seen that tonight was going to go until just 8 o'clock. That was in error. We are going to go until 8:30. And again, you're going to have an opportunity to ask questions. He's another gentleman with a lot of information, very good information. And I want to thank both our presenters. I know this about Joseph, and I want to thank what I saw with Dr. Fall, in that I think you can tell that they really do care about their patients. And I think that's very evident, and obviously about you too. So without further ado, I'm going to let you, Dr. Pandit, I'm going to let you share a little about yourself, and then your presentation, and let us know if you need us to share screen.
Sure. Hi guys, can you hear me okay?
Mm-hmm.
Okay. Robin, I'm looking to maybe share a screen here.
Okay, Doc, can you, you should actually, Dr. Pandit, you should be able to go to the bottom.
Yep.
And see where it says share screen, and you should be able to do that. I don't think it'll take any special permissions or anything. You should be able to do that.
I do see the stop video, and I pulled up the share screen.
Mm-hmm.
So we can.
And if we have to, Don, if we have to stop videotaping in order to share screen, and if Dr. Pandit can, I don't know if you'd be willing to share your PowerPoint with us. So folks, if we don't record this necessarily, you can still get information. Does that sound good?
Are you not able to share the screen, Dr. Pandit?
I'm not, but I'll tell you what I can do actually from my side. It's not as important. So I can just kind of go along with my slides.
Okay. All right.
But
either way works.
All right. I'll just go ahead and introduce myself. I'm Joseph Pandit. I'm a clinical pharmacist, worked with HCA for quite some time. I imagine some of your family members may have been at some of the HCA facilities, be it Parthenon Pavilion or Skyline Madison in the Nashville area. Of course, we now have Pinewood Springs down in the Columbia area. Of course, there's all various facilities in the Middle Tennessee area. I want to thank our previous presenter as well. And as you all gathered, it's a pretty complex situation when it comes to diagnosis and timelines and symptoms. And sometimes there's a lot of overlap in gray area. So getting the history of symptoms, family history as well, substance abuse can increase those complexities. Of course, as you're all also familiar, and I heard a few questions previously regarding medications, as far as stability and then changes in medication can be very frustrating for not only the patient, but their families, because we want what's best for them. We want to improve their quality of life. And sometimes it does require what would seem to be trial and error, as well as input from the patient. So what I'm going to do actually right now is I'm pulling up my slides. I'm not able to see you guys, so you're welcome to speak up and interrupt in case you have a question in the middle of it. Again, I am a clinical pharmacist. Some of you may not really be familiar with what that is, but I work inpatient traditionally. I work on the floors, so I'm not actually counting the pills, that you might think of with the traditional, more community pharmacy. I round on the units, see the patients personally, face to face. I'm a consult for the providers, be it the psychiatrist or the other MDs or nurse practitioners or the PAs, because as our patients come in, not only are there challenges with the psychiatric meds, but many times our patients are coming in with issues of blood pressure or infection control or cholesterol, diabetes, asthma, COPD, all these comorbidities that we might think of that can also make the behavioral health issues more challenging. So what I'm going to discuss today is just kind of give you guys a brief introduction of what we look at with pharmacy, and then really discuss some more specifics in regards to the drug classes themselves. We'll talk about maybe some of the barriers to therapy and how to address them, and maybe some of the controversies involved with psychiatric medications. I will point out that I am not a paid representative for any medical or pharmaceutical company. I'm currently a clinical pharmacist with Monogram Health out of Nashville, and I do actually float part-time with Kroger Pharmacy. For me, it's important that I kind of keep in touch with that retail market so I can stay familiar with the challenges that our patients have with insurance and prior authorizations and timely fills of medication. When it comes to medication, we are what some might feel to be an over-medicated society. In the last decade and decade plus, we see about a quarter of Americans on a psychotropic medication. When I say psychotropic medication, I'm referring to those really centrally indicated, that is for the purpose of a behavioral health illness, be it anxiety, depression, schizophrenia, bipolar disorder, substance use disorders, ADHD perhaps. So some people wonder, are we over-treating? Are we over-medicating people? Or rather, are we able to diagnose and treat illness better than we ever have before? Beyond that, I would say is agencies like NAMI and others across the United States and the world continue their efforts to reduce the stigma of mental illness. We have more people seeking out help. So while we might have more of a population on these medications, I think there's a variety of reasons for it. Currently, antidepressants are really the most commonly used because they do have a variety of purposes, be it anxiety, depression, of course. We think about maybe PTSD type scenarios. But we've also seen a vast increase in ADHD meds as well as antipsychotics. We know, obviously, from the earlier presentation that for family members or we ourselves that might be on medications such as this, the illness itself can be unpleasant, and that's putting it mildly. Can be irritating to deal with. Sometimes it's irritating for the family members, especially when our loved ones may not be on a medication that suits them well to the point that they stop taking their medications. As far as impact on families, we know how it can cause adverse reactions, side effects, of course, monetary issues where they can't access the meds or access a provider. Patients are missing work or leaving work. They're finding challenges in finding or utilizing community resources to help them cope. And families like you guys, you might feel isolated and very alone. You're not sure really who to turn to. As far as an impact on healthcare, probably in the next decade, we'll see that 40% of patient visits themselves to pediatricians will involve not only the long-term treatment of chronic disease, but would also be considering behavioral health conditions. We see practitioners with improved training, improved response, improved testing and evaluation to look at some of these disorders as they begin to manifest at an early age. As far as a team-based approach, which is what I practice with, we obviously have the team leaders, which would be our physicians and NPs and PAs, but it's a longitudinal relationship that, in my opinion, is led by the patient themselves. We can't just throw a pill at a patient and expect them to buy into it. We need to explain, we need to help them understand, comprehend the necessity of the medication, that it's not just a medication to treat an illness, acutely. It's more of something that they may need lifelong. We relate it to, say, high blood pressure or diabetes, that while you might feel better on the medication, it's important to continue that therapy to maintain stability and perhaps rehospitalization. So I'm going to talk a little bit about the nerd stuff we do in the pharmacy world. Let me make sure I'm looking at faces here to make sure no one's asleep yet. I don't see anybody nodding off yet. Robin, alert me if I hear snoring. Everyone's muted right now.
If I can see them snoring, we'll let you know.
Is there a snoring emoji anybody can throw up at me with some Z's on it or something? So when we're in pharmacy school, we discuss, it's not chemistry labs that some of you might think of, and it's not learning how to count pills across a tablet tray like you might think of at a CVS or a Walgreens. We really think about how the drug impacts the body. So we talk about pharmacokinetics. That is, what does the body do to the drug? When we think about some aspects we think of as ADME, there's absorption, distribution, metabolism, and excretion. So if we were to sit and kind of talk about it, dialogue, where does a drug absorb? And if I were to kind of get a show of hands and we would say, where does a drug absorb? And you're going to all say the stomach. And well, maybe that's part of it. But what about a lotion? What about a cream? What about a nasal spray, right? What about an injection of some type? Suppositories, throat sprays. So these are where drug would absorb. And all of these are created in a chemical balance. So there is a difference between a lotion and a cream and an ointment and the impact it has on that site of action. There is a difference between an elixir, a suspension, a solution, liquids we might consider. So these are aspects of the drug formulation that impact how quickly it can work in the body, whether or not it repels water, absorbs through certain sites of the skin, be it muscle or fat. And then we look more closely at that aspect and what we refer to as distribution. That is, where does it go in the body? Then we look at metabolism, which would focus more, say, on liver type kinetics. Some drugs that we give might be in a inactive form. It passes through the bloodstream into the liver. The liver actually converts it into an active form. We might see it active in the beginning into the liver and then deactivated. We can see it active in the beginning through the liver and further active as a metabolite. And then we look at excretion or elimination, and that's more of a kidney impact as far as, think about the kidney like a pool filter. And as drug goes through there, some medications are not impacted by the kidneys at all. Some are not impacted by the liver. We think about Tylenol, and someone that would take an excess of acetaminophen could actually be damaging to the liver. We know that some medications that need to be cleared out by the kidneys, if a person has reduced kidney function, then they need to reduce a dose, or instead of taking it twice a day, maybe reduce to once a day. So it's important for practitioners and patients to understand the need for certain lab monitoring. That's why some of our family members might be getting drug level monitoring, et cetera, to make sure they're on an appropriate dose that's effective for them, and at the same time is being cleared from the body sufficiently that the levels don't increase and become toxic. The example I typically use in the regard to dose, some people wonder, well, how do you know that my loved one needs 20 milligrams of olanzapine or 500 milligrams of valproic acid or Depakote? So we think about the science behind the studies, the pharmaceutical companies that do the lab work and the studies, be it animal testing and then progressed on to human studies. They do the research to identify what is an appropriate therapeutic dose. And that's why you see, say, on a label for ibuprofen, Advil, it might say take 1 to 2 tablets every 4 to 6 hours, because we know that in the traditional sense of kidney function, which is where ibuprofen is cleared, that there's a range that we need to take at least this much, at least 200 milligrams of this drug to be effective, and really no more than 400 milligrams. And this is, of course, is over-the-counter dosing about every 4 to 6 hours, because that's how long it takes for the kidneys to clear that drug out. To take an excessive dose or take it more frequently could then impact the body's ability to clear it and thereby increasing toxicity. And I always use that example for some of you that may have remembered there's a famous I Love Lucy episode. Remember when they're in the chocolate factory? And it's like her and Ethel, and the chocolates are coming down the conveyor belt, then it comes faster and faster, and it's falling on the floor, and Lucy's eating them and putting them in her apron. That's what would happen if you take drug more frequently than is designed. Too high of a dose, it's becoming an excess, and then we might achieve a level that we would refer to as toxic. Toxic does not necessarily mean death. It could be kidney damage. It could be increased sedation. It could mean some skin disorders, dermatologic reactions, seizure. So there's lots of different things that could occur if you achieve an excessive dose in the toxicity. Sometimes those adverse events or even the side effects could occur within the therapeutic window, which is why we know even if you take, say, a normal standard dose of Benadryl, it's going to make me sleepy. I took the appropriate dose, but sedation is a very common side effect. And truth be told, there are occasions where we actually can use a side effect to a benefit. That's why Benadryl is not really only used for allergies, but some people might take it for insomnia. You mix Benadryl with Tylenol, that's Tylenol PM. That's exactly what that is. We're using it to help for insomnia. Any questions so far about that? I think that's pretty cut and dry, right?
Now, I do have a question,
Sure.
and I'm wondering, how do enzyme imbalances or thyroid disorders throw off medications in the body, and what do you have to worry about with psychotropics with stuff like that?
Sure. So for the medications, and most of the psychotropic medications are processed and metabolized through the liver.
Okay.
These enzymes, if you can think of them as little molecular level Pac-Men, they chomp away at the drugs, okay? And you could actually take medications that distract, if you will, those little Pac-Men. Those Pac-Men can only eat so much of drug at the same time. And if you happen to be a Pac-Man that likes pizza and chicken nuggets, and I put both into the body, they can't eat the pizza as rapidly if they've got chicken nuggets that are kind of in their face as well. So if I'm giving you 2 medications that are both metabolized by the same available enzymes, that drug, actually both of those medications will increase in level because there are not sufficient amount of enzymes to focus on the one group. We are seeing in the past decade plus more science that's related to what we call pharmacogenomics, that is gene studies. So we're seeing a lot of patients being referred to laboratories. Your doctor's office might even draw a sample and send it off, because we can now do testing to identify beforehand if you have a genetic predisposition for low levels of those enzymes, or maybe higher levels of those enzymes. If you have a higher amount of those Pac-Men, and I give you a dose that's routine for most people, but giving it to you, that dose may not be enough. I'm giving you 100 milligrams, it wears off through the day or doesn't work at all. We may have to double the dose or try a different medication altogether. So that's a concept. We refer to those enzymes as cytochromes. And so it's very important in the pharmacist perspective to be able to identify drug interactions in relation to those enzymes. And that's what we do. Physicians are also very well trained in this as well. And their training is very substantial in diagnostics. And I find that sometimes they rely on nerds like me to be able to look at those enzymes and provide input if they request it. But for the most part, everyone I've worked with in the past is just, they keep up to date. They have had plenty of education, and they stay in the know, especially with the new stuff coming out. But you're right, we find that some medications can interact. There's actually some of the antipsychotics. We might think about olanzapine, maybe clozapine, where smoking can actually reduce the levels of those drugs. It's not the tobacco necessarily or even nicotine. It's something about the smoking that we would say induces, that is, increases the metabolism, so that when we've had patients in the hospital, we get them stabilized on a drug like Zyprexa, let's just say 15 milligrams. But if we know that they're going to resume smoking when they go back home, we might discharge them on a higher dose, because getting home and smoking 15 milligrams may not be sufficient. So if you find that an issue, then that might be something to point out to the outpatient provider. Did that answer your question, Robin?
Yeah, interesting. Thank you.
Yeah.
My name is Tony. I have a question in
Sure,
regards
Tony.
to minorities and medication. From what I understand, minorities, specifically African Americans, seem to metabolize the psychotropic medications differently. Is that true? And if so, why is that?
You know, we do see that with some medications. I've seen it more so in some like antihypertensives, say like blood pressure medications. Unfortunately, some of the science is out there. I'm afraid that some providers don't maybe fully see the benefit in the testing, because ultimately they're going to just either increase the dose or change the medication if they're not seeing the results as rapidly as they would like. But we are, as we do more, genome studies, genetic mapping, we understand that, be it along race lines or, perhaps lineage of some type, that we do see some medications prove ineffective. And I think the science is still trying to catch up to that, especially when it comes to behavioral health medicines. If we all here had an upper respiratory infection, it's allergy season, we think about sinus infections, I could probably put everybody on some amoxicillin or some augmentin or a cephalexin, and we'd see some benefit probably for the majority of the group. But with behavioral health meds, it's not like that. And I don't know that it's always because of a genetic origin, but it's sometimes just tailor-made to the patient. And frankly, the science when it comes to psychotropics has not fully revealed that to us. But you are right, Tony, we do see some aspects where perhaps minorities, African Americans, we do see some of the Asian population where certain medications are not as beneficial as perhaps like Caucasian counterparts.
I'm going to ask, Teresa, did you have a question?
Yes.
All right, and then Jill will get to you after Teresa asks hers, okay?
My screen had froze. I don't know if you guys had froze. I lost my connection, so I missed some of what you were saying.
Okay.
But I'm a legal guardian for my niece, and she's in Georgia, and I'm here in Tennessee. I did finally get a list of all of her medications, and I did ask, she goes to a program, where they teach life skills and get her injections and so forth. And so I had asked the caseworker, and I sent a note to the nurse because I'm concerned about her taking, they give her a shot of Invega Sustenna, and they give her, where's that other one? Here it is, Seroquel.
Okay.
So she gets Seroquel as a tablet and the other one as an injection. And both of those are supposed to be antipsychotics. She was diagnosed with Schizophrenia Affective Disorder by the court. That was 2 years ago. And I asked them about these two medications. At what point maybe did the doctor do a reevaluation, because I've researched and it says long-term use could start this tardive dyskinesia, movements and stuff.
Sure.
So I didn't want her to just be, just go there and they just plug her up, because she's awful after she get her shot.
Awful how?
Well, she's
awful how, Miss Teresa?
Tired, sleepy, and she tries to call me and everything's all slurred and everything. After a couple of days, she's back to quote normal. But the effect that it has on her, and these two together, I just have a concern, because I've only been involved in her situation for 2 years, but she's been out there for years. She's 51.
Yeah.
So I don't know how long she's been taking, getting these shots either through the Cav Regional, the psychiatric hospital or Grady or whatever. But can you shed any light on this muscular problem that could develop for long-term use?
Absolutely. So Ms. Teresa's asked a very good question. I would imagine that several of you here have family members on an antipsychotic. And I can tell you on the surface, that sounds like a very frightening term. I think Dr. Fall answered earlier about the concept of psychosis. We think about delusions and paranoia. She mentioned positive symptoms, negative symptoms. So we see patients not only present with hallucinations and delusion, but we see them have the negative symptoms of perhaps what appears to be depression, lack of interest in the fun things, sometimes speech disturbance, thought disturbance. And so that's very complex, especially trying to determine origin, be it drugs or is this bipolar disorder or schizoaffective disorder. If I relate this perhaps to, let's say, blood pressure. Early on, years ago, if someone was diagnosed with high blood pressure, the doctor might say, hey, start taking some walks around the block, cut back on your salt, lose some weight. And then some new guidelines came out and said, hey, what are you waiting for? The longer you let a patient stay with high blood pressure, the more likelihood of some complexities of, end organ damage, stroke, cardiovascular disease. Newer guidelines even say, hey, why are you waiting, with just one med? We know that most people won't be controlled with just one. We might need to go ahead and start them on 2 medications as soon as you diagnose it. When it comes to antipsychotics, we have a breakdown of basically 2 branches. We have the older ones, the more traditional antipsychotics, and then we have the newer ones we refer to as the atypical. So typical and atypical. The difference is in the mechanism of action. And so antipsychotics treat psychosis by blockade of dopamine. Some of the newer agents actually have impact on serotonin activity. The difference between those classes of drugs is how it impacts the severity perhaps, or maybe how potent the activity is at dopamine. And that's where we see, Ms. Teresa, some of those movement disorders, like you mentioned, tardive dyskinesia. They can oftentimes manifest early on as Parkinsonian type symptoms. Patients might have hand tremors or shakes. We might see their head begin to, do a wobble. We might see a shuffling gait, perhaps. Some patients get this almost inner restlessness, and they can't quit pacing, and they can't sit down. And this isn't anxiety. It's not, nerves. They're not just tapping their foot. They very physically can't sit down, and it's exhausting. Some people, when trying these medications, especially those older ones, you might think about Haldol, haloperidol, fluphenazine, perfenazine. They might even go so far as cause what looks like a muscle cramp. Their neck might tighten, their head will twist. I've seen eyes roll back, their tongue protrude. In fact, when you get some of that tongue and throat, some patients might think they're having an anaphylactic reaction. You think about bee stings, peanuts, that kind of swelling. It's not swelling, it's more of like a muscle spasm there at the throat, what we call dystonia. So as we work on those dopamine pathways in the brain, they can then progress to a more severe chronic disturbance called tardive dyskinesia. I'll never forget a patient that I had to work with in residency. She had such a profound movement. I mean, she was gyrating, her head moving all around. She can't sit still in the chair. She's making facial movements, lip smacking. We refer to pill rolling, which is an old reference to how pharmacists would actually create handmade tablets. So they get, again, some of these Parkinson-like, small gestures, but maybe some larger, grander type movements. Some of these medications have a stronger propensity, that is more potency in that dopamine activity. And to avoid that, we might then give another medication with a lower effectiveness or a lower impact on those type of movement disorders. So Invega Sustenna, available as an injection. Invega is actually also available as a tablet. It is actually the metabolite of Risperdal, which I'm sure some of you have heard of that as well, risperidone. So like I mentioned earlier with the metabolites, if you take Risperdal, when it passes through the liver, it actually becomes Invega or paliperidone. Then they created a shot form of it for patients that really might have difficulty taking tablets daily. They're better, adherent to a regimen if they're getting a once a month shot. We know there's several reasons that patients cannot or will not take medication. Risperdal and Invega both have a very strong, potent activity on that dopamine system that lends itself to some of those movement disorders. Not only that, we see elevations of prolactin. So we see males grow breasts. We call it gynecomastia. We see women, actually not even pregnant, begin to lactate. So to avoid some of those symptoms, a provider may give a lesser dose of the Invega or the Risperdal or other medications similar to it, and then give another medication like Seroquel, also called quetiapine, to also provide antipsychotic activity without, again, contributing to some of the movement disorder. The other thing is, we also look at what we'd say is dose-dependent activity or purpose. Seroquel, although extremely effective with schizophrenia, schizoaffective disorder, it is one of the recommended medications for patients with bipolar disorder, say in combination with lithium. Seroquel can also lend itself to benefiting a patient with bouts of agitation, anxiety, perhaps insomnia. So we have patients that may oftentimes take Seroquel at doses from 25 milligram to 150, maybe 200 milligrams, really to, on its own, perhaps be for anxiety, agitation, or sleep. If as a lone therapy, that is monotherapy, patients may be upwards of 300, 600, 900, I've seen 1,200 milligrams of Seroquel. Again, that's really as monotherapy. So I'm not sure, I believe, Ms. Teresa, you said your niece, but I'd wonder what her dose is as far as the Seroquel. My assumption.
Seroquel is 300 and then Invega is 234.
Yeah, 234 for the Sustenna is the recommended maintenance dose. I'm actually very surprised that she's having that reaction so quickly after the injection, in which case the doctor may find the lower dose, which is 156 milligrams, to be a preferential dose for maintenance. The drawback to that is, if we kind of think about that therapeutic window, most patients receiving Invega Sustenna would require that 234. If we were to lower the dose, we may minimize some of those side effects, but at the same time, it may not be the effective dose to treat the psychosis or the schizoaffective disorder, in which case, perhaps the doctor would consider lowering the Sustenna to 156 and then perhaps going up on the Seroquel. The challenge with that is I don't know if your niece is fully adherent to taking oral medication. The shot may be the very thing keeping her out of the hospital, which is something we also have to consider as family members and caregivers for our loved ones, is trying to make them stay adherent or help them understand it, because they don't like the way these medications make them feel. Continuing to have that lethargy or all those symptoms they get after the shot, all of a sudden that loved one of ours starts to miss appointments. They don't take their pills every day like they should because they don't like how it makes them feel. So I would ask, if you've communicated this to the provider, and I wonder what feedback they gave to you.
Well, I haven't heard back from the nurse, and I guess it's time for me to make a trip to Georgia. I'm actually trying to get her into another medical center,
Sure.
South Side, and possibly a different program.
Sure.
That, pay attention to these kind of things.
Yeah.
Her biggest complaint is that Invega, when she has
Yeah.
to get that shot, she says, I hate that shot because it makes me, drowsy, and then she can't get it. She takes the other medicine. She doesn't complain about that.
Okay.
But she does tend to complain about that shot.
Yeah, well, I think the conversation like you're suggesting would be in order to, kind of verbalize those concerns. They may find a reduced dose or a complete change in medication to be the best option.
Yeah.
Thank you, Teresa. Jill, did you have a question?
Yeah, I do have a question. My question is about Depakote.
Sure.
My daughter is diagnosed bipolar 1, and they tried her on, she's an adult. They tried her on every medicine, but Depakote's the only one that's working. And her weight was going back and forth so much. She'd go on the Depakote for 2 months, lose 30 pounds, go off it, go off the Depakote, lose 30 pounds, go back on it, gain 30 pounds in 2 months. And it seems like there's nothing else that's working for her, but she's gained more than 30 pounds now. She's very active. She's a PA. She's a traveling PA. And she's athletic, but it's still not enough to keep her weight down. And I don't know, is this metabolic issues? Is it just making her want to eat all the time? Is there any other option other than the Depakote?
So yeah, for bipolar 1 disorder, we would look at the guideline therapy. So we talk about what's evidence-based. So we look at studies that are identifying appropriate doses, appropriate drug combinations, what works basically. And we know that Depakote is one of the first-line therapies for patients with mood disorders such as bipolar. Sometimes it requires, again, combination therapy with one of the antipsychotics I mentioned earlier. So when we look at side effects, be it sedation or weight gain or movement disorders, we think about the antidepressants that many commonly are causing sexual dysfunction, which is enough of a reason for a lot of patients to quit their medication. And when it comes to weight gain, that's tricky as far as the drugs go. So your question was, is it something metabolic that causes weight gain? Yeah, we're not really sure the etiology of that, but we do see a very strong correlation of patients that are on Depakote and weight gain. With antipsychotics, we do see weight gain as well. There's a metabolic concern. At the same time, we also see patients basically, they get the munchies. They just want to eat everything in sight. So when we look at a side effect, we have a few options. Number one, just change the drug.
Well, but all the others that they've tried don't work for her.
Yeah, and so that
she has been a psych PA up at Genrose at Mayo Clinic. She's tried everything. Yeah. Now she's traveling. None of the others are working for her.
Sure. And so, me being the person I am, when I get, some like a family member of the patient to say that, I'd say, well, let's sit down and actually take a medication history. Let's really see what you have tried. Mm-hmm. Because I'm sure she's been on a lot of stuff, but as many medications as there are, she probably hasn't tried everything. So not only is there the options of changing the drug, sometimes stopping the drug. And that isn't, of course, with a lot of the illnesses we're discussing here, the appropriate therapy, that is to stop a medication altogether without replacing it.
Well, she said she can't stop it because if she does, then she doesn't sleep, and she can't work if she doesn't sleep.
Of course. So stopping the medication also does not sound appropriate in this scenario. So then we might also discuss, like I was mentioning with Ms. Teresa and her niece, maybe reduction of the dose and perhaps an addition of another medication would be worthwhile looking into. So I don't know if she's on any other kind of psychotropic medications other than Depakote, but she may find some benefit in reduction of that dose and then addition of another low dose of a medication to stabilize.
Okay, thank you.
Yeah.
Thank you, Jill. Dr. Pandit, I see Lynn Hayes has her hand up.
Yeah, Lynn.
Yes, I have a question about medication.
Sure.
My son is the one past schizophrenia. Schizoaffective.
Schizoaffective,
Right. And it's bipolar, associated with bipolar disorder. Mm-hmm. Okay, so he was taking olanzapine.
Okay.
And so and Depakote, and that was beautiful. Then they changed him took away the olanzapine and gave him Abilify.
Okay.
And now we're in trouble. What's the difference between Abilify and the olanzapine? Does Abilify work on bipolar too?
It does. It does. And so, like I was mentioning earlier, as far as maybe some of that dopamine activity, olanzapine, which is also known as Zyprexa, is in the same, what we'd say, second generation, the atypical antipsychotics. and as well as Abilify. Abilify, for some of you, is also known as aripiprazole. That's the generic name.
Right, that's what he has. Okay.
So when we look at those, we look at, again, if we think they are equally effective for psychosis, we then have to move on to the determination of what are side effects that the patient can tolerate. Olanzapine, from a study years ago, was at the time found to be the best tolerated of the antipsychotics. It had very little of the movement disorder concerns. However, everybody in the study at some point quit taking the medication that they were assigned as part of the study. Olanzapine was the one that people quit taking after the longest amount of time, and it was because of metabolic issues. When we look at those second generation antipsychotics, we don't see as much of the movement disorder as you would with first gen, but with the second gen, it's weight gain, it's increase in cholesterol. Some patients are developing diabetes. We're seeing what we call metabolic disorder, which is where they have, we call it a truncal obesity. That is the torso of the body, the belly fat. So it's not just, I gained weight all over, you know, they're not a 320-pound linebacker. It's all around the midsection. And we know also from the evidence that patients that have that torso, that truncal obesity, have a higher risk of cardiovascular events. So higher risk of stroke, higher risk of heart attack. Olanzapine lends itself as a greater risk than Abilify. So my assumption, and it may not be correct, but my assumption is to switch from the olanzapine to the aripiprazole was likely because of some changes metabolically. Either the patient was gaining weight or they were seeing perhaps, progression perhaps towards diabetes. You know, they check blood glucose. Another lab we look at more specifically is called an A1C, which is how we monitor for diabetes. A lot of the providers I see, though, if a patient is stable on a medication, you know, it's kind of that if it ain't broke, you know, why try to fix it? And you guys, I'm seeing heads nod across the screen here. You all look like the Brady Bunch, by the way, on my screen. But you know, these patients are, yeah, the patients are doing well. They're sleeping, they're not agitated. We don't see the frequency of symptoms reappearing, you know, hospitalizations. But sometimes doctors may get the concern, hey, there's a lab I'm a little worried about. Maybe the patient expressed something to the doctor that said, you know, I don't fit in my pants anymore, or I don't, you know, I'm gaining weight, the scale is kind of creeping upwards. So the doctor might be inclined to work with the patient in order to change that therapy. So if we see cholesterol changes, my opinion would be to keep them on the current antipsychotic and maybe add on a cholesterol. You know, I wouldn't necessarily do it preemptively, that is prophylactically. I have a couple of doctors that try to do that. They start a patient on, say, Zyprexa or something similar, and then they want to throw them on a diabetes med to prevent them from heading that direction, which really isn't appropriate. The evidence doesn't really support that, because we also know that adding on a medication increases the complexity of the regimen. It's one more drug to remember, one more drug to pay for. So adding on a medication isn't always the best scenario.
Isn't there something about, I think there was a concern about the liver or something with olanzapine?
Well, kind of across the board, there's not really as much of an increased risk as far as a liver damage. We might see fatty liver, and you might see some liver enzymes starting to change a little bit, but it doesn't really have much of a difference than Abilify in that regard.
Well, Abilify is not working. He's going to Catatonia.
Wow. And so, yeah, you guys all heard Dr. Fall, I believe, earlier discuss catatonia, and you know, on a very objective note, it's fascinating. And as a family member, it can become very dangerous, you know, if they're not eating and hydrating like they should, you know, functional in any kind of manner. I would urge the doctor to reconsider that change. You know, I would ask also, what was the drive to change it in the first place? Can you help me understand that? And if the patient is now decompensating, returning, especially to something like catatonia, I think that would warrant revisiting that regimen and going back to something you knew that worked. And if there was a concern other than, psychosis or mood, if it's again weight gain or something else metabolically, you might be able to address that with another medication.
And so this is my very last question.
You better not be, Miss Lynn.
I get what you just said made it seem that I should go back to the place that made the change. I need to take you to the doctor.
Well, whoever is prescribing the Abilify now is who I would consult.
Go back to, okay.
Yeah, I would go back to
All
that.
right.
Whoever's doing the follow-up at this point is who I would work with. Now,
All right,
one more
thank you.
thing you're very welcome, Ms. Lynn. One more thing to consider is in the transition from olanzapine to Abilify. Sure, there is the precaution that this drug just isn't going to work for this individual. However, we know that Abilify works for most people that take it for be it mood disorder or schizophrenia. Maybe they're on too low of a dose of Abilify.
Yeah, it's 5 milligrams.
5?
5.
Yeah, that's a pretty low dose. That is a very low dose.
Okay,
Yeah.
and the olanzapine was 10.
Yeah.
And so all right, I'm gonna have to be an expert in this. I can't.
Yeah.
I mean, I can't be your expert, but I'm gonna have to
No,
learn
you can.
this.
You can. Come on.
Because,
We'll converse after this if you want to, but
okay.
Olanzapine at 10 milligrams is a pretty common dose. With more severe forms of psychosis, schizophrenia, we might see upwards of 20, perhaps 30 milligrams of Zyprexa. But I can tell you that 5 of Abilify is low.
Okay, well, that's what he's on. So probably that's what's caused the issue.
Yeah, I see patients more commonly on 15 to 30 milligrams of Abilify. So the provider may have intended to start at a lower dose to see how the patient responded, with the intention of what we would say is titrating upwards. We want the lowest effective dose. We know that with a lot of these meds, the higher the dose, the more likely the side effects and complications.
Okay.
They might do better in a higher dose, Ms. Lynn.
Okay, and the Depakote was, oh dear. It is 500 milligrams.
Yeah, 500 is a not uncommon dose. If they're on extended release, perhaps 500 once a day. The Depakote probably won't have as much to do with their conversion into catatonia. We would see more impact from an antipsychotic. But the Depakote would definitely serve more as a mood stabilizer, say from mania to depression, and vice versa.
Thank you so much.
You're welcome,
Thank
Ms. Lynn.
Thank you.
Thank you.
Amy, did you have a question?
Yes, I was wanting to ask about Effexor. I am trying to taper off of it because I am finding that the side effects of it are giving me the same thing as a drug addiction feeling whenever I don't have it. I know that the psychiatrists and different ones tell me that it's non-addictive. However, you can't tell me when I miss a dose that it's non-addictive because it sure doesn't feel like it.
Well, Miss Amy, tell me what those symptoms are like when you don't take your dose.
Oh, let's see. I'll get the ringing in the ears, the zapping in the head, the turn your head a little bit and you'll feel like you're going to fall over, sick to your stomach, you name it. But as soon as you get that dose back in there and raise it up a little bit, you're good. All that stuff goes away. And I've been on it since 2009. And so I have bipolar 2 as what my diagnosis is. And was put on it for major depression. And so I'm trying to, my doctor and I are trying to work me off of it, but I'm finding that I'm starting to have the problems again. And I'm having to say, whoa, back up. We can't reduce it. Not like you typically would reduce something.
Sure.
And is that normal or should you be able to get out of it, where you reduce it a half a dose and then you know what I'm saying?
Yeah. So we use certain terminology, in describing how these medications work. For example, in school, we were taught kind of early on, quit referring to patients not taking their meds as being non-compliant. If we say compliance, that implies, I told you to do something, Amy, and you're not doing it, so you're not following my orders. Instead, we should say, refer to adherence. And that implies maybe a softer tone. That's you and me working together and teamwork. It's all, you know, it's just words. So when we talk about some of the psychotropic medications, we really don't refer to withdrawals, because I think that might give more of an implication of, say, someone having withdrawals from alcohol or opiates or those kind of street drugs we might think of. So instead, with especially antidepressants, we talk about not withdrawals, but a discontinuation syndrome. You're with me there? It's all
but it sure don't feel like a discontinuation syndrome. It feels like going off of Xanax.
And well, hopefully you're not trying that one either.
I've done that already.
Oh, wow. Goodness. Miss Amy, if you were in my office, we would have what we refer to in the medical field as a come to Jesus meeting, okay? And I would say,
tell me about
what in the world are you thinking? Why in the world are you missing your doses? So unlike Xanax, now Xanax has a very strong risk of withdrawal seizures, maybe even death. That's dangerous to fool around with. So some addicts or people that are physically, you know, addicted to the medication by no fault of their own, it's just a medication they've been on for a while, they would need to be tapered. So when we look at antidepressants, perhaps like Effexor, which for those of you out there is also called venlafaxine, we do see a discontinuation syndrome. I would want to, you know, ask, like, why are you missing doses? Is it trouble remembering? Are you running out? Is it an expensive med that you don't get refilled? But
no, I've always remembered to take it. It's just the effect that I'm getting out of it is the withdrawal symptom. I feel like I'm stockpiling it to where if you don't give it to me on time, I'm going to be, you know what I'm saying?
Well, who's giving it to you?
My doctor is, but I saved it up over time, and I've got a stockpile to where if they don't call it in or I don't get to the appointment, guess what? I got some pills.
So I would want to make sure that you are taking the dose as prescribed every day. We know also, and I believe Dr. Fall could speak to this, you know, perhaps better than I could, but when we look at the disease states, if you will, you know, anxiety, and, you know, we have a varied spectrum, everything from stage fright to a chronic generalized anxiety disorder. We look at depression, and we see some research, it could be very situational. Imagine a loved one passes away. You know, as time progresses, perhaps you're better able to deal with the grief, and maybe so without a medication. Some people might have a more chronic type depression where the medication is on board for a much longer time than, say, with other forms of a mood disorder. So yeah, with depression, there are occasions and appropriateness to come off of that medication. I would never recommend for someone having been on the med for quite some time to just abruptly stop it. Some of these medications would require a very slow taper over several weeks at reduced dose. So yeah, we won't often see the brain zaps and things like that, you know, with maybe just one missed dose. But if that's what you're feeling, then by all means, you know, we'll take that into account. So yours might require a much slower taper. Now you're mentioning perhaps more current diagnosis of bipolar 2. That is a diagnosis that most often is going to require lifelong therapy, whether you want to be on a pill or not. You know, I actually wear an insulin pump now. My blood sugar will be good. My A1C should look good. That does not mean I come off my med. I'm staying stabilized because of that insulin. And so you may feel better while on the medication, and it may be something that's required for you lifelong. There's no current therapies for bipolar disorder that say you take it for a while and come off of it. Now, Effexor may not be appropriate for you, although some patients might benefit from an antidepressant. You might do better with, say, a mood stabilizer like we discussed with some of the other patients, such as lithium Depakote or one of the newer generational antipsychotics. So the Effexor, yeah, I'd wonder again about the missed doses. You're saying stockpiling, which in my brain tells me you're like storing nuts for the winter like a squirrel rather than taking your medication. But yeah, even being on perhaps an extended release version of the Effexor would also prevent some of those discontinuation type symptoms
I was gonna
as it
ask
lasts longer.
With that, I have a gastric bypass. It's over 20 years old.
Then you know exactly, yeah. So you aren't really the appropriate candidate for some of those extended release drugs.
Right.
Correct.
So I was wondering, how is extended release starting to affect gastric bypasses that are that old? Are we getting to where we can handle extended release now?
Nope.
Because not everything's absorbed in the stomach, and it's not all
Sure.
absorbed in certain places in the intestine, which is
Yep.
totally something I understand.
You are
So
exactly right, though, Ms. Amy. Extended release as a general idea is not appropriate for patients with gastric bypass. And actually, more specifically, patients that have had the Roux-en-Y bypass.
yeah,
Now, some patients, perhaps with a sleeve or a band may do okay with an extended release, but those versions, except for a couple of medications out there, not even psychotropics, they should not be crushed or chewed or split. So in your case, extended release, sustained release, those are not appropriate for you.
right. Because we're having trouble with my Seroquel. He's
Okay.
trying to use me on extended release, but I'm having to take it so early in the evening to get it out of my system to be able to drive the next day.
You should not be on extended release, Ms. Amy.
Okay,
Yeah.
that's what I thought.
Yeah. And you guys are all, some of you have done this for long enough, this stuff, and I'm afraid that we just have the culture. You've got that, we talk about white coat syndrome. You go in the room and the doctor tells you what you're going to do. And you're like, okay, you nod your head. And in the back of your head, you're saying, this doesn't seem right. Why are they changing my medication? Why aren't they listening to me when I tell them I've had gastric bypass?
I'm just like, maybe they did something to extended release that I didn't know that happened.
They did not. And you probably went through some preoperative, education that told you, hey, you shouldn't take extended release after this procedure. And yet you have a doctor, maybe they forgot. It's part of your chart that they don't look at regularly. So, you should give them a call or next visit, say, hey, I don't need to be on this, because you're right. It might exit the system a little slower. You're likely also not getting the full benefit of the Seroquel you're taking because it's passing through the system in a sense faster than you can absorb the benefit.
Yeah. Okay. Well, I appreciate it. Thank
You're
you.
welcome.
Well,
Hey, Robin, how are we doing on time here?
I
It's
was
like
just gonna say, we are right at time, and I was gonna ask you to speak on advocacy, and you just did.
Okay.
So I really do appreciate that. Guys, we really are, we have come to the end of our time. If you'd like to make some closing remarks for 5 minutes, Dr. Pandit, and then we'll announce tomorrow's public education night. So if you'd like to do some closing remarks, then I'll close this out.
Absolutely.
That would be great.
Dr. Fall started out this evening with just the challenges for the patient in expressing their symptoms, challenges on the provider side from kind of picking through all of it to see what are we really dealing with. We have to rule out medical issues, substance use disorders as well as getting an accurate history from the patient. There could be the patient that presents with some depressive symptoms, and then they may have some underlying manic episodes that pop up, but that's just days the patient feels better and doesn't think to speak up about it. So the patient gets treated for depression rather than perhaps bipolar disorder. And then the complexities of finding a medication that works. Are they on the right dose? Are they on other medications that render the first medication ineffective? Is it too expensive? It doesn't make me feel like myself. I'm not happy. I'm not sad. It's causing trouble in the bedroom. There's lots of reasons that patients cannot and will not take their medications. We have agencies, again, like NAMI that address the issues of stigma. A lot of patients that want and need and crave to be on some sort of therapy opt not to seek it out for fear of judgment from the community, from their family, from coworkers, because they don't want to be on a medication. They don't want to be seen as someone on a psych pill. I'm not crazy. I don't need to be on this. You're the one with the problem. There's so many issues that stem from this and getting appropriate treatment. These are patients that need to follow up appropriately, be it yourself or your family members. And you guys, like I said in the very beginning, as far as I'm concerned, you are the leader of this treatment team. You are in charge of this. No one knows what's going through your head or your loved one's head except for them. You don't have the lab technology. We can't have an x-ray of your brain and go, well, there's your schizophrenia right there. We can't draw blood and determine, well, here's how high your bipolar level is. We treat it for symptoms. We treat it for remission. We treat it with the best medication that the patient can take. It requires lab monitoring. Sometimes it requires navigation through an insanely complex insurance system of prior authorizations and refills and dose adjustments. And it can get so confusing. And sometimes our family members are just throwing their hands up and said, I don't even care anymore. Sometimes they just feel better and quit taking it. I feel good right now. And then in a couple of weeks, the psychosis returns and they're not even aware of it. They just wake up in the hospital and don't know how they exactly got there. So there are clearly some challenges to this, but I know that you guys are keeping an eye on family members. Miss Teresa down there is gonna go give some doctor what for and put her opinion out there on the table. And so I want you guys to advocate. There are people like Dr. Fall, there's people like Robin that I know will do their best to meet the patient needs, and myself. And I would say that the vast majority of practitioners of any type in this field of working with this population do it because we want to. You're part of my community, and it serves me better if I'm being selfish to make sure my patients are being treated well. And it's for the betterment of all of us. So feel free to speak up, express your concerns. On the flip side, don't start Googling information and tell Dr. Fall what kind of medication you want to be on because you saw a really cool commercial with a butterfly on it. Some of those medications are not appropriate for our loved ones. There's a reason and a rationale for why we do it. But again, as the leader of the treatment team, you deserve to know why. If it's complex, ask why. Sometimes I might get into a scenario where I start using big words and don't even think about it. If you don't understand it, ask. There's no harm in asking what that word means. Why are we checking for levels? Why is it this frequently? Why are we adding this drug? Why are they not on this dose? When do you think I will expect improvement? How long do I need to be on this medication? These are questions that I want you all to feel comfortable with, as well as your loved ones. And sometimes we just go in there and feel nervous and just do what the doctor says, and trust them, as we should. But please speak up and express your concerns.
Yeah, thank you so much for that, Dr. Pandit. Thank you, because that is so important. That you do that you advocate for yourself, your loved ones. And I can tell something that we always recommend is that you keep a log. And I can tell from Teresa's notes and Lynn's notes and Amy's, you guys are right on top of what's going on. Yep, there's Lynn, Teresa's got her. So we recommend that you have I used to have for my sister who was in an institution for 13 years, I had a Jody book, and everything went in the Jody book, and the Jody book got to be pretty darn big. But they knew when we called that institution. My mother had a Brooklyn accent, and the head of that facility would answer the phone and go, "Yes, Mom." Not even her name, he knew who it was. So I think just join me and thank you both, Dr. Pandit and Dr. Fall, because